Welcome to the floor. Imagine we're about to start morning ward rounds. You've got a patient with failing kidneys, and the attending turns straight to you for the diagnosis. It's a high-stakes moment, right? Well, in this clinical explainer, we're going to arm you with exactly what you need to survive it. Today, we're mastering one of the absolutely most critical distinctions in renal medicine, nephritic versus nephrotic syndrome.
Okay, let's dive into this. When a patient presents with renal failure, the symptoms can honestly just seem like this confusing blur. Swelling, weird urine, alarming blood pressure readings. But hidden within that whole clinical picture is a very distinct path that tells you exactly what's going on at a microscopic level. So you have to ask yourself, are the kidneys inflamed and angry? Or are they simply leaking like a broken sieve?
To answer that, we'll be relying on a master framework throughout our explainer today. This single matrix of symptoms, pathophysiology, and lab findings is literally the definitive guide to surviving your renal rotations. If you can master how to read these specific patterns, you'll never mix up these two syndromes again. Seriously, it's a real game changer. So let's break this matrix down piece by piece.
Part 1. Inflammation versus filtration defect. Before we get into the weeds of blood tests and urine samples, we really need to establish the foundational rule that separates these two presentations. So here's your golden rule, clearly contrasted. On one side, nephrotic syndrome is driven by inflammation, and that inflammation leads directly to hematuria, which is blood in the urine, plus hypertension. But on the flip side, nephrotic syndrome is entirely a filtration defect. The filter is broken, and that leads to massive proteinuria, so protein leaking into the urine, which is then followed by severe edema and hyperlipidemia. So just remember, inflammation means bleeding and pressure. A filtration defect means leaking. Keep that rule locked in your mind as we go.
Part 2. Nephrotic syndrome, the inflamed glomerulus.
Let's focus entirely on this first clinical presentation, the angry kidney. When we look at the primary pathophysiology of nephritic syndrome, it all starts right at the glomerulus. The glomerulus becomes actively inflamed, and because of this severe inflammation, there's actual physical damage happening to the capillary walls. Imagine the tiny blood vessels inside the kidney basically getting battered and breaking down. Naturally, when a capillary wall is damaged like that, red blood cells escape. They just leak right out of the bloodstream and directly into the urinary tract.
Now, what's really interesting here is how that microscopic capillary damage translates directly to the patient sitting right in front of you. Because those red blood cells are leaking out, hematuria is super prominent. But it's not just your run-of-the-mill blood. You're going to see RBC casts and dysmorphic or oddly shaped red blood cells. Why? Because they've been squeezed and distorted through that damaged, inflamed filter. You'll also see some proteinuria, but it's mild to moderate, strictly under 3.5 grams per day. And because the inflamed kidney isn't filtering fluid properly, well, the patient retains fluid, making hypertension incredibly common.
And if you want to confirm all that immunological anger, you just have to look at the blood work. In nephritic syndrome, complement levels, specifically C3 and C4, are often low. Why is that? Well, because the immune system is actively using them up to drive that glomerular inflammation. Some classic examples you'll definitely see on the wards include post-streptococcal glomerulonephritis or lupus nephritis. So that low complement level, that's a massive clue.
Part 3. Nephrotic syndrome, the leaky sieve.
Leaving the angry, inflamed kidney behind us, we shift over to a totally different pathophysiology. Here, the damage is localized specifically to the podocytes. Now, these are those specialized cells that wrap around the capillaries and act as the kidney's crucial filter. When the podocytes are damaged, the glomerulus becomes incredibly permeable. It completely loses its ability to hold back large molecules, specifically proteins. Basically, the filter is busted.
And because that filter is busted, protein literally pours out of the body. To even call it nephrotic syndrome, the proteinuria has to be massive. We are talking strictly greater than 3.5 grams of protein lost every single day. That is a truly massive scale of loss, and it sets off this devastating chain reaction throughout the patient's entire body.
And this brilliantly illustrates the logical cascade that follows. Step 1 is the massive proteinuria we just talked about. The patient is losing all this protein, specifically albumin, right into their urine. Then, step 2. Because of all that loss, the blood levels of albumin just plummet, resulting in marked hypoalbuminemia. Finally, step 3. The liver panics. It sees the low protein levels in the blood and kicks into overdrive to compensate. But while it's desperately trying to synthesize more proteins, it also pumps out massive amounts of lipids. So this liver overcompensation causes marked hyperlipidemia. It's a perfect, tragic domino effect.
Part 4. The clinical showdown.
So, we have the angry, inflamed kidney on one side and the leaky, busted sieve on the other. Now it's time for a rapid-fire bedside comparison. Let's start with swelling, or edema. In our nephritic patient, the edema is pretty mild to moderate. You'll classically see it periorbitally, so around the eyes, especially in the morning when the patient first wakes up. But look at the nephrotic patient. Because they've lost all that albumin, they've completely lost the oncotic pressure that normally holds fluid inside their blood vessels. The result? Severe, generalized, full-body edema, which is known clinically as anasarca.
Next up, blood and pressure. Remember our golden rule from earlier? Inflammation drives bleeding and pressure. So in nephritic syndrome, hematuria is prominent, and hypertension is super common because of that fluid retention. In stark contrast, our leaky nephrotic patient usually has absent or only microscopic hematuria, and their blood pressure? It might be completely normal or just mildly elevated. So at the bedside, the distinction is really crystal clear.
Let's move to the urinalysis showdown and see how this builds on everything we've discussed so far. You send off the urine. The nephritic sample comes back looking like a microscopic battlefield. You've got red blood cells, RBC casts from those damaged capillaries, and only mild proteinuria. The nephrotic sample, though, comes back completely different. It is totally dominated by heavy proteinuria and something entirely unique, fatty casts.
That brings us to a massive, super high-yield clinical buzzword you have to know, lipiduria. Because the liver is overcompensating and flooding the blood with lipids, those lipids actually spill right into the urine, and under a polarized microscope, these lipids appear as Maltese crosses. If you ever see fatty casts or Maltese crosses on a lab report, it absolutely guarantees a nephrotic diagnosis. You will never ever see this in nephritic syndrome.
Part 5. Your diagnostic pearls.
We've covered the microscopic damage, the domino effects, and the bedside showdown. So the crucial point is, here is your ultimate diagnostic cheat sheet, derived straight from our framework. If you suspect nephritic syndrome, your absolute key feature is hematuria with RBC casts. It's the smoking gun that proves inflammation and capillary damage. But if you suspect nephrotic syndrome, you are looking for that classic clinical triad: massive proteinuria, which leads to hypoalbuminemia, resulting in generalized edema.
And that brings us to the end of our ward round explainer. You now have the master matrix decoded. So, the next time you walk into a hospital room and see a patient with severe swelling, abnormal urine, and failing kidneys, ask yourself, is it inflamed or is it leaking? Will you know exactly what their glomerulus is doing? Keep these patterns locked in, and you absolutely will.